to put together some of the key messages that we got from the speakers this morning. So, to start, what is shock? I think that's important to remember because really everything goes into the recognition of this. If we recognize that we have a patient in shock, then we can start to think about the different mechanisms for it, the different reasons for a patient to be in shock. But first of all, really, we need to understand that the patient is in shock. And therefore, we really need to remember that it's a life-threatening, generalized form of acute circulatory failure associated with inadequate oxygen utilization by the cells. And usually, in this setting, lactate levels are elevated. And we heard from Professor Vincent about the importance of the clinical examination and how lactate levels can be used at least to have a feeling about the severity of the patient. Lactate levels are not always elevated only to problems of oxygen delivery. I will talk a little bit about this tomorrow, but it is true that in the initial phases of shock, at least should be a warning signal that is telling us we have a problem. And no matter which series of data you look at, a high lactate level is usually associated with worse outcomes. Funny enough, even for lactate levels, when you start to go from 1 to 2, which we don't consider an abnormal lactate level, still statistically, your survival drop compared to lower lactate levels. But of course, it is when we start to see lactate levels of 3 and 4 and they don't clear, those are the patients with the worse outcomes. Now, sometimes I hear a conflict between what is more important. Is it more important the perfusion, the peripheral perfusion and the lactate level, or is it more important the hypotension and the fact that the patient is valvoplegic? Well, I don't think we can make a rule about what is more important. I think it's about recognizing what's out there, and I think both things are important. For a cell to work, we need an adequate oxygen delivery, but we also need an adequate pressure for that things to be delivered properly to the cell. So perfusion pressure is important. And indeed, if I look even just at single hypotensive episode into an emergency department, we know that even those patients that resolve the hypotensive episode, maybe with some fluids, and then they go to the ward, well, those patients are associated with worse outcomes. So for instance, having a systolic value of less than 80, just one, is associated with a significant mortality of about 16% in hospital patients. Now, in this study, we don't know what was the level of lactate. The truth is that in real life practice, sometimes when we get these patients into our departments and we see that they improve quickly, maybe we're not so worried about it. Still, having an episode of vasoplegia, it's a problem. And therefore, the message is that the de novo hypotension should be considered a medical emergency. I really like this study by the group of Shapiro because I think it tells a better story than just looking at hypotension or hypoperfusion. There is clearly a synergy here. If I have a patient that is severely hypotensive and hypoperfused, those are patients that are very, very sick, often very difficult to manage, and in which really we need to intervene very fast. But still, if you look, for instance, at patients that you wouldn't define normally as severely hypotensive patients, so with a systolic of more than 90, still having a lactate of more than 4, well, these patients have a mortality in the range of 20%. These to me are the ones that are very difficult to spot if you're not very careful. It's very easy to spot an hypotensive patient, maybe with not a very high lactate level. We see these patients in front of our house. We are called by the nurses, we are called by the other doctors in the emergency department. It's a bit more subtle actually to spot that the patient can be in shock, even when the blood pressure may be perceived to be normal. And these are really the patients in which I think we have to focus, not to miss the boat here. Of course, that I will say, you can see there is a clear synergy here. If I have severely hypotensive and severely hypoperfused with a lactate of more than 4 and a systolic of less than 70, these are really those patients in which we have to intervene very fast, and I think sometimes even consider very early extra monitoring and extra safety nets for these patients. So, what about hypotension? What should we do? Well, we said in our consensus that arterial hypotension is often present, and therefore a patient that is hypotensive should at least give us a warning to consider whether the patient is in shock. But it should not be a rule-out mechanism to say that that patient is not in shock. So I can be in shock even with a systolic blood pressure that is more than 90. What do we do with blood pressure levels? We heard this in the previous talks. I think the message that came out is that we need to individualize this as much as possible to preserve the auto-regulation of the organs. In real-life practice, though, it's not so easy to know if a patient was working on a systolic of 170 over 120 at home or 120 over an 80. So I think we have to be a bit pragmatic, and even if the studies that have shown us that going for higher values of blood pressure didn't show any improvement in outcome for these patients, we know that some patients may improve with a slightly higher level of blood pressure. So what should we be doing? I think for the majority of patients, probably starting with a map of 65 seems to stay on the safe side. But there is a group of patients in which if we don't see that they improve quickly, and maybe we know that there is an history of hypertension and we see that the kidneys start to fail, probably think about having a sort of a noradrenaline challenge and see if the perfusion of those organs can improve. May not be necessarily a bad idea. How did we summarize this in our consensus? Well, we said we need to individualize the target blood pressure, but we didn't want to give the message that a blood pressure of 40 on admission to the emergency department was a good thing. And so we said that at the beginning, let's start with a map of 65 millimeters of mercury. Then we have a bit of time to think if that patient may tolerate something lower or maybe needs a bit higher. But when we don't know anything about this patient, let's stabilize the situation, and then we start to do the fine-tuning of where we are with that. Of course, for trauma patients, we put an exception there. If you don't have a head injury, you may tolerate that because that's something done to try to stop the bleeding, which is a bleeding we need to intervene surgically for it. And as I was telling you before, in septic shock patients, we suggest, not a recommendation for everyone, but we suggest to consider in those patients maybe to go for a higher level if we think that the autoregulation of the kidneys may not be preserved with a lower value. Now, we've been talking a lot this morning about strategies and monitoring, but the thing that has come out, I hope, is the concept that we really need to understand if our manipulation of cardiac output is useful to improve the perfusion and therefore to understand where we are in terms of balance between oxygen demand and oxygen delivery. Now, I'm not going to go into the detail of rivers, which has been mentioned a couple of times this morning. But the big question is really, what do we do with the SCVO2? The SCVO2 up to some years ago was almost like our golden variable. We have to optimize the SCVO2 in every patient, and when we achieved the 70, we were happy. I think that approach probably was not the right approach either even at that time, as I will show you in a second, and as he was saying before in the previous talks. The SCVO2 is one variable, it's just one of the variables that we have. And if you remember the multicentric trials that have tried to replicate rivers recently, they didn't show any improvement in outcome at all comparing standard practice against a therapy that was aimed at targeting an SCVO2 of more than 70%. This was really very consistent. There even being a meta-analysis, which of course was showing negative results, considering that all the studies were negative. But let's go back to the reason why Rivers did this study. He wanted to see whether an haemodynamic variable that was giving us an idea about the demand and the balance between oxygen demand and oxygen delivery could give in this specific group of patients extra ways of targeting therapy. Now, if the goals were achieved, then you were not doing anything. So let's have a look at the baseline of the studies that have tried to replicate Rivers recently. The ARISE study had a mean SCVO2 of 73%, the PROSE a mean SCVO2 of 71%, and PROMISE a mean SCVO2 of 70%. Now, the question is, are we looking at the same population that Rivers looked at many years before? Probably not. Rivers had a mean SCVO2 of 49%. I would argue that Rivers was instrumental in giving us an idea that we need to recognize a shock in septic shock very early, intervene very fast, start to give the fluids very fast. This has changed dramatically the approach with the Surviving Sepsis campaign, with a lot of the campaigns around the recognition, giving antibiotics fast, trying to do some sort of optimization with fluids very, very fast. And as you see, nowadays, we're probably a bit better than 20 years ago, and that's a good thing in recognizing, and I suspect in treating some of these patients. So by the time we measure an SCVO2 now, often this patient already had an initial fluid resuscitation. Does it mean that the SCVO2 does not work? No, it doesn't mean that. It means that the clinical research question in the studies have changed, because probably the population that we're looking at is now different. So what if the SCVO2 is not enough? Well, if the SCVO2 is not enough to guide our therapy, we need to go back to basics, and maybe we need to go back to physiology. For me, the fact that the patient has an SCVO2 of 7%, it does not mean that I've reached my target. I still have to go back and understand if there is still a problem with the perfusion of that patient or not. But on the other hand, in the occasional patient in which I have a central line and I measure an SCVO2 and maybe it is 55%, I should not ignore that. That's not what the studies told me. What the study told me is that nowadays the population, when I measure an SCVO2 in the emergency department, seems to be a bit different, because probably, as I said before, we're intervening probably very early. Now, some of the problems of the SCVO2 when you reach levels around 70% is that it becomes blind to what happened in different areas of the microcirculation. So I could have an area of the microcirculation that is well perfused, is using oxygen, and is delivering a bit less oxygen back to the venous compartment. I could have, on the other hand, an area that is a bit more shunted. Some of the oxygen will go there, but not as much. The cells have to try a way to survive, so therefore they will increase the anaerobic metabolism. I will have a bit more lactate production here. The CO2 increase will be disproportional, so therefore I will have a bit more production of lactate and CO2 on this side of the microcirculation. What it means? It means that if I mix everything here, if I look at the SCVO2, it could be normal, because simply I'm not extracting much on this side, so I could have a lot of oxygen coming back here. I could have a low oxygen levels here, but when I mix, I really become blind to what happened. On the other hand, maybe I can focus on some of these parts here. I know that the lactate is high, because we're talking about shock, but maybe I can start to look at this value here of the CO2 to give me a feeling of where we are with the perfusion. And indeed, if I look just at the SCVO2, patients with a normal, considered normal SCVO2 can still be patients that respond to fluids, for instance, with an increase in cardiac output. And those patients may still benefit from fluids if there is evidence of still inadequate organ perfusion. So when I asked Emmanuel Rivers to write this review for Current Opinion on Critical Care, he was also having the same feeling about the SCVO2. If the lactate is high and my SCVO2 is low, I should not ignore a low SCVO2. I can still use it. And if this is guiding my therapy and the lactate becomes normal and the patient is improving, and maybe now the SCVO2 is normal, maybe I can even stop. However, in those patients that have not been able to show a kinetic of the lactate that is decreasing fast, and I still have evidence that the clinical examination is telling me that there is still hypoperfusion in this patient, having a normal SCVO2, for instance, with a normal lactate, is not of any use. I need to think about something extra there. And on the other hand, a high SCVO2 and a high lactate, again, that's not something that I can use to guide my therapy anymore. So in this sense, something that is becoming more and more popular, at least with data from observational studies, is telling us that if we looked at the difference in carbon dioxide between arterial and venous blood, that could give us some extra information about the adequacy of the cardiac output in our patients. And therefore, how would I put all these variables together? Well, I think that every time we have a patient in shock, if there is vasodilation, I should really try to keep the mean arterial pressure. We wrote 60 here, 60 because it's really to stay on the lower conservative side, but I would say 65 should really be our initial goal. I should try to clear the lactate, but clear the lactate is not because I want to artificially decrease that number, it's because when the lactate is high, it's telling me that there is still a problem that I've not been able to resolve. If I have a central line, I will look at the SCVO2, and if the SCVO2 is low, then I will start to think, what is the reason for that imbalance between the oxygen delivery and the oxygen demand? Is there a problem with anemia? Is there a problem that maybe the arterial oxygen saturation is not enough? Or is there a problem with perfusion? If there is a problem with perfusion, then I would argue that still giving fluids, probably at the beginning, it's not a bad idea if I've not tried that therapy yet in those patients. I will talk a bit more tomorrow about how to identify very vasodilated patients in which we may have to start a vasopressor early, as Jean-Louis Touboul just said. And in those patients in which the SCVO2 is high, then I would argue, let's have a look at the gap of the CO2. And if the gap of the CO2 between the arterial and the venous side is higher than 6 millimeters of mercury, then again, this is a patient that may still benefit from a therapy that tries to improve the cardiac output and the oxygen delivery to the tissue. That we can do with fluids, or we may even do with some inotropes. So what was our recommendation in trying to put all of this together? We say that if you have a central line, we don't suggest to put a central line to measure an SCVO2, but if you have a central line, and that probably is because you are receiving already a norepinephrine infusion, or the doctor thought that you were sick enough to deserve one, we said, well, it takes very little to do a venous blood gas. Let's measure that. If the venous saturation is low, it's still telling us something important. If the venous saturation is above 70% and have an arterial line, why don't we do a measurement of the gap of the PCO2? It costs very little. It can give us very important information about the physiology of that patient in that moment. We talked about monitoring as well today, and what was our point of view in terms of cardiac output monitoring and echocardiography and so on. Well, the truth is that a lot of patients, if we recognize them very early and we treat them fast and we give them antibiotics and we give fluids very fast, they will improve fast enough so that maybe we don't need to go on more advanced monitoring. But, and that's what we do for a living, we take the sickest patients in our intensive care unit. If there isn't being an improvement fast enough, I would argue those patients probably deserve some extra attention, and therefore, whatever tool you want to use, whether it is echocardiography or something different, measuring cardiac output in those patients can give us some important information if they've not improved quickly to the initial therapy. And we also said that basically when you do that, you should really use some more advanced monitoring. Using just blood pressure or invasive blood pressure is not enough. Echocardiography, we do believe, is the way to go, at least at the beginning, to do a fast assessment. But then there are a lot of variables that we can put together. We heard about CVP, we heard about volumetric monitoring, we heard about echocardiography. To me, these patients are complex. I cannot think about managing one of these patients just with a lactate level of 1 or with SCVO2 or just with looking at a picture on an echocardiography monitor. I need to put all of this together. And to me, really, coming to the conclusion of my talk, I would always say, always let's go back to the basic. The very first question should always be, is there evidence of tissue dysoxia? If there is evidence of tissue dysoxia, then the next question, if I'm thinking about haemodynamic, would be, do I think that the manipulation of cardiac output can improve the tissue perfusion? If I answer yes to both questions, then I can start to think about what is the best strategy to do that. Is it sometimes an early vasopressor, sometimes an inotrope, sometimes a bit more fluid, sometimes a bit less fluids? If I don't measure, I don't think I will be able to know. So to conclude, in our consensus, we suggested that when further hemodynamic assessment was needed, echocardiography should be used, and I think that's an important message. I think nowadays basic echo skills should be part of our way of being an intensivist at the bedside. It's about point-of-care testing. It's not about being experts echocardiographers that can do an exam a day. We need to be able to do this examination every time we need, or we ask the clinical questions about it. And we also say that in some patients, probably the use of pulmonary artery catheter or transpulmonary thermodilution can be useful to find maybe better ways of understanding the mechanisms of that shock. If you want to have a feeling of what is our view on how to monitor this patient, we put this together into this paper, which was driven by Jean-Louis Touboul and the cardiovascular dynamics section of the European Society of Intensive Care Medicine. So if we think that there is acute circulatory failure, if we think that there is shock, We need to put all these variables together. We need to look at arterial blood pressure, lactate, and markers of perfusion. We do believe that echocardiography is really important and is key in the central assessment here together with our clinical examination. And then we can think about which devices to use. To conclude, I think always let's start with this very important question. Is the perfusion adequate or not? I think the message from this morning is that also we should individualize therapy and also to consider advanced monitoring, especially in those patients that do not improve rapidly. And remember, there is not one monitor that will fit all the type of shocks and all the type of patients that we have.